Yeah, this is the last topic before quiz. I know energy and uh, this thing are trending out rapidly. So today's talk is exploring LDLC management challenges in very high risk ACOD patients. So the thing is that nowadays we are having 4 or 5 strong arsenal in lipid lowering therapy. We know statin, the high dose statin number one, number two is ezetimibe. Next come ezetimibe, bempedoic acid, and injectable therapies. We know that this lipid lowering can be categorized in 4 categories. Number one, low risk. Next, high risk. Next, very high risk. Next, extremely high risk. So, according to ESC and CSI 2023, low risk. I first sum up this thing first. Yeah, low risk means no risk factor. Even if there is no risk factor, the LDLC should be below 100. This is the dictum of today's world. In India, as we are seeing a sea changes in dyslipidemia and diabetes, we see every other person is having diabetes, hypertension, and dyslipidemia. So, extreme caution must be exerted in Indian patients. Every Indian patient should have LDLC less than 100. That is low risk. High risk is diabetes with one or more risk factor. Next is CKD EGFR 30 to 60. Familial hypercholesterolemia no risk factor. Hypertension plus one risk factor. Hypertension plus target organ damage. So these things are high risk. Here LDLC requirement is 70. Very high risk, that is ASCVD, established ASCVD. Diabetes for more than 20 years. CKD EGFR less than 30. Familial hypercholesterolemia plus ASCVD. This is a very high risk group. LDL cholesterol should be below 55. And then extremely high risk where there is a familial hypercholesterolemia plus ASCVD plus elevated LPA, or patient is having severe ASCVD, that is 2 or 3 occasions patient having bypass surgery or angioplasty or any other pan arterial disease, and event occurred in 2 years, more than 2 in 2 years. So this is categorized as extremely high risk, that is LDL cholesterol should be below 40. So initially guidelines were saying that if with statin, high dose statin, we can expect that 50% LDL cholesterol reduction we can expect. Somebody is having LDL cholesterol 150, we can expect his LDL cholesterol will be around 70 by high dose statin if he can tolerate that thing. But this extremely high risk or very high risk, LDL cholesterol below 40, LDL cholesterol below 55 cannot be achieved usually with high dose statin only. So we have to use other therapies along with high dose statin. So 2 or 3 cases, arbitrary cases. Ava is a young successful software engineer. He is having hypertension. He presented with NSTEMI, underwent drug-eluting stent placement in RCA and currently hospitalized. LDLC 154. Therapy, atorvastatin 40, ezetimibe 10. So we know that this is a very high risk case. So LDL cholesterol should be below 55. With atorvastatin 40 and ezetimibe 10, we can at best can gather around 50% to 60% LDL reduction. With atorvastatin 80, maybe around 60 or 65% LDL reduction, not more than that. So LDL cholesterol less than 55 cannot be achievable with these two medicines logically. Next, patient Ramesh, 60 years old gentleman, undergone 2 PCI in last 3 years, hypertension and diabetes. This is also a very extremely high risk because 2 PCI in 3 years, their LDL cholesterol goal is 40. Current LDL cholesterol 80, rosuvastatin 20 plus evolocumab, that is PCSK9 inhibitor every 2 weeks. So here we can see here we are having a scope of elevating rosuvastatin more than 20, that is 40 plus ezetimibe plus bempedoic acid and PCSK9 inhibitor. We can at best achieve an LDL cholesterol around 50-55%. To make it below 40, it's a humongous task. We know it. Next is Mrs. Kalpana, 52 years old, having hypertension and obesity. NSTEMI, underwent PCI for multivessel disease, 2 drug-eluting stents, 1 in LAD, unrelated RCA. This is a very high risk, if not extremely high risk. So LDL level, LDL goal is 55 here, according to ESC, and her LDL cholesterol is 120. LLT is rosuvastatin 20 and ezetimibe 10, we have a scope of increasing the rosuvastatin to 40, then add bempedoic acid with all these things, we can expect an LDL cholesterol lowering at best 60-65%. So here LDL should be around 60-65. It is maybe in this case it is achievable around 55 LDL cholesterol with these medicines can be achieved. We can see after 3 months. So both the three categories are very high risk. Probably second one is extremely high risk. So here the LDL cholesterol should be minimum at least below 55, if not below 40. So this is 2023 CSI guideline, extremely high risk below 40, very high risk 55, ESC extremely high risk 40, very high risk 55, and non-HDL cholesterol is a plus 30. So the notion is strike early, strike strong. So whenever a patient is having an event, strike early. So with some studies we can comment that initially when the patient comes with ACS and you are doing an angioplasty or medically treating the patient, along with your loading dose of aspirin and clopidogrel and atorvastatin, we can use this some other molecules, injectable molecules, so that this ACS, this hemodynamic perturbation or metabolic perturbation goes on around 1 week to 2 weeks. And that is the exact time when you should hit hard with this LLT, so that anti-inflammatory and all those beneficial effects fall into place. So guidelines are recommending that you go for a highest dose of statin if the LDL cholesterol or non-HDL cholesterol level is not achieved after 3 months, or after 2 months you add ezetimibe, you add bempedoic acid with that therapy. If you achieve your LDL goal, that is fine. Otherwise, you add injectable molecules. 2 injectable molecules we have right now in our hand. Number 1 is PCSK9 inhibitor. Number 2 is inclisiran. So approach is like that. Goal not achieved. In these 3 cases, here we can use injectable molecules like PCSK9 inhibitor or inclisiran. So we know that long-term LDL cholesterol reduction leads to proportionally greater reduction in the lifetime risk of ASCVD. Each millimole per liter reduction in LDL cholesterol reduces the relative risk of ASCVD event by around 10% in the first year, and in 40 years it is around 50%. So the basic thing is strike early, strike hard, and strike continuously, because this pulsation, there is a tendency that patient is taking statin, definitely high dose statin, but irregularly. Patient is someday he is taking, then next day he is forgetting about this drug. So this ups and downs in the LDL cholesterol, this is also very much bad. You have to continuously suppress the thing for long decades, so that your ASCVD event will be reduced. Can be reduced, or we can think of reducing that in long run. So continuous suppression of LDL cholesterol is also very important. Pulsatile pulses ups and down in LDL cholesterol is also bad. It modulates your gene. So currently available lipid lowering treatments, what we have in our hand: statin, ezetimibe, bile acid sequestrants, bempedoic acid. Recent therapies, PCSK9 inhibitors, aleducumab and evolocumab. Newer therapies, that is inclisiran and bempedoic acid, already we having in our hand, and some emerging therapies. I'm not going into details of that emerging therapy. These much strong arsenal we have. So whenever we are facing this kind of patients, that ASCVD patients, established ASCVD, so we can think that these patients may develop another event maybe by 5 years. Especially in productive life, in younger age group, we should go all out from the very beginning, from the very first day, so that LDL cholesterol target could be achieved and patient will be free of any ASCVD event further or death further. Combination therapy is needed to achieve lower LDL cholesterol goal reduction. Here from the very beginning, if we achieve, if we go for a combination therapy, maybe atorvastatin 40 plus ezetimibe, and then escalate atorvastatin 40 to 80. So that is maybe a better thinking, as guidelines are recommending. Moderate intensity statin has the capacity to reduce your LDL cholesterol by 30%, high intensity by 50%, high intensity plus ezetimibe 65%, whereas if we add bempedoic acid is at most 65 to 70%, PCSK9 inhibitor plus statin 75%, PCSK9 inhibitor plus statin plus ezetimibe 85%. So if we really target, lowest or least is the best one, that is LDL cholesterol more than less than 40, we have to use other molecules, innovative these kind of molecules or genetic silencing to achieve this much humongous task. So more intensive LLT associated with LDL cholesterol, low LDL cholesterol and risk of MACE. Here we can see the orange, yellow and green bar, how this can translate logically into lower events. This is a miracle and A to Z trial we can see here. So evolocumab resulted in target LDLC cholesterol level within 4 weeks after the initial event, allowing over 95% of the patient to reach the target LDLC level. We can see this thing. CV outcomes. Addition of ezetimibe showed an event rate for the primary endpoint at 7 years was 32.7%, 2% absolute risk difference. Here we can see in the plot of forest plotting, that is deep and shallow your blue lines. So impact of PCSK9 on patients with prior PCI at 48 weeks, that is around 1 year. Pre-specified subgroup analysis from Fourier trial, that is LDLC reduction more than 60%, major coronary event reduction around 20%, need for additional PCI or further events or target-based revascularization reduces by around 20%. PCI at de novo lesion, the fresh lesion cropping up, that is around reduction is around 20-25%, and PCI at previous stents or graft vessel, that is ISR and stent-related complication or graft-related complication, that is a de novo or ISR, that is less than, reduces by 20-24%. So all here we can see that every coronary events, almost every coronary events reduces according to the trial. So this much benefit we can get, why not to add in a therapy if all the logistics and everything permits. So inclisiran, some few words. What's the difference between this PCSK9 inhibitor and inclisiran? This is liver specific. It acts upfront. It causes genetic silencing. So no genotoxic or carcinogenic effect in evolocumab or PCSK9 inhibitor. Also, we do not get that thing, but there is a probability. No effect on fertility or embryonic development. So in pregnancy, we can think of this thing. No dose adjustment necessary for patients with renal or hepatic impairment is extremely difficult. Whatever be the patient's situation, whatever other risk factors or other metabolic factors patient is having, you can add this thing. You cannot, you should not, or you don't have to think about the creatinine level. Don't have to think about your PT, SGOT, where many cases we stuck because we cannot, if the enzymes are very high, more than 3 times or more than 4 times, so we hesitate to escalate the statin doses. In those cases, definitely it is a big boon. So it achieved a mean more than 50% reduction in LDLC in pivotal phase 3 trial. With inclisiran, 68% of the population achieved an LDLC less than 70 and 52 achieved an LDLC less than 50. So in India, the utilization of statin is less than 20%. As Dr. Tibrewal was saying that ARNI uptake is around 5%. Maybe in this 2024, some South Indian study came that ARNI uptake is around 10%. At best, you can expect that in 2024 it is 10%. ARNI is a newer molecule, but statin is an age-old molecule. Its uptake is around 20-25%. In a good dosing, where we can expect that atorvastatin 5 or atorvastatin 10, these in this dosing we cannot expect an LDLC reduction in our achievable target, but uptake is really low in Indian perspective. Internationally, it is around 70-75% the statin uptake in a good dosing. So this is Orion. We see this thing. It's a backup study for heart study for inclisiran. So these exploratory outcomes offer early insight into the potential CV benefits of inclisiran and suggest that this approach may provide CV benefit. We know that it has a CV benefit definitely, with reduction of composite MACE 3 point and 4 points, both MACE. So Orion 8 is a long-term efficacy of twice yearly inclisiran dosing in high cardiovascular risk patients. 78% patients achieved their pre-specified LDL target, that is 55. Pre-specified in these categories, very high risk categories. 90% 90% of the patients achieved their global lipid target at any visit. On average, LDL reduction were reduced by at least 50% at that visit. Um, uh, So this is usual the dose schedule, that is one at day 0, then 3 months, then 6 months, and every 6 months. We can skip this 3 months in Indian perspective. I mean, we don't know the exact data how this is working in Indian continent, but anyway, those who are using this maybe using day 0 and then every 6 months. Dose, we know this twice yearly maintenance dose, there is no loading dose kind of thing. Ability to achieve to 2023 ESC guidelines, at least 50-60% achievable, well tolerated, side effect profile is minimal. So the takeaway for today is ACS patients like these three cases are very high risk patient, if not extremely high, and require an early and continuous intensive lowering of LDL-C cholesterol. Latest guideline recommend LDL cholesterol treatment goal should be less than 55, if not 40. PCSK9 inhibitor plus high dose statin plus ezetimibe. This is a standard regime. Probably, if you at all think of reducing LDL cholesterol below 40, rapidly lowers LDL cholesterol, sustain LDL cholesterol reduction over a decade. Safety profile is favorable and dosing is extremely favorable. So thank you.